Bismillahirrahmanirrahim. Today, today's quote is have more than you show, speak less than you know. Today we are going to critical appraise and randomized control trial article using the CONSORT checklist. The article's title is Human papillomavirus based screening, cervical screening and long-term cervical cancer risk, a randomized control trial, please see in Sweden. I am Dr. Mohammed Abbasgil. I am PGR of Community Medicine and I am giving this presentation under the kind supervision of Professor Dr. Saira Afzal. Here are the links for the consort checklist and randomized control trials. I am going to add critical appraise the article by each slide having the each point of the consort checklist from the article. No, from the title and abstract, we have in the first point we have to identify whether the article has included the randomized control trial in the title or not. Yes, the title explicitly states the human papilloma-based cervical screening and long-term cervical cancer risk or randomized healthcare policy trial in Sweden. In the next point, we have to state whether the structure summary of the trial design, methods, results, and conclusion. Just the abstract is structured with subheadings such as background, methods, findings, and interpretation. It summarizes the trial design, key results, and conclusions. Next, introduction. In our introduction, we have to identify the scientific background and explanation of the rationale. Yes, the article explains the shift to have a human papilloma-based cervical screening and need for real-world evidence to complement findings from the research trials. In the next, we have to identify the specific objectives or hypotheses. Yes, the objective is to evaluate which policy, whether HPV-based or cytology-based screening provides better protection against cervical cancer after two full screening methods. Here is the article. Here is the introduction. They states that cervical screening is a globally recommended public health policy. It is a major pillar of WHO call for global elimination of cervical cancer. International guidelines recommended that cervical screening should be performed using primary testing for human papillomavirus DNA. These recommendations are based on a series of randomized controlled trials that have found HPV DNA testing to have a better protection against invasive cervical cancer compared with previously used screening method that is cytology based. Cervical screening has switched to HPV-based screening in many countries, but there are still countries that use cytology as a primary method for screening. Next, they've explained what is meant by the randomized healthcare policies. Trials in the research setting used to target selected groups of participants and are run under the stringent conditions and are not attainable in real-life healthcare. It is therefore imperative that trials in the research setting are complemented with studies in real-life settings. For maximum reliability, such studies should also be performed under a randomized design, so-called randomized healthcare policies. Next, they have given the evidence in the introduction for this study. They have stated that they have collected the data from different databases from January 1990 to August 2014, and they have collected this. They have in this study they have collected this data from till 2024. A pooled analysis of four European randomized controlled trials reported superior performance of HPV-based screening as compared with cytology preventing uh, uh, a report analysis of four European randomized clinical trials reported superior performance of HPV-based screening as compared with cytology for preventing cervical cancer with a 60 to 70% greater protection against invasive cervical cancer in HPV-based screening as compared with cytology. Two randomized control trials have been conducted with only one trial with invasive cervical cancer as endpoint published. This study found no difference between HPV-based screening compared with the cytology. Added value of this study. Our study is, to our knowledge, the largest randomized real-world trial to provide real-world evidence that HPV-based screening is superior to cytology-based screening for preventing invasive cancer. This evidence is in line with the findings in clinical trials in this research setting. The implications of the available evidence. The findings of the previous randomized control trials and this large randomized cervical screening policy support the global implementation of HPV-based cervical screening and highlight a need for future screening to research to improve triaging women who test positive for HPV as screening. This and the trial, its implementation, and the baseline results on detection rates of high-grade lesions according to the two different policies have been published. This study aimed to evaluate which policy provided better protection against invasive cervical cancer at 8 years of follow-up after the full 2 rounds of screening. Now, coming towards the methods. In method, we have to, in the first point, we have to identify description of a trial design, for example, parallel or factorial, including allocation ratio. Yes, the article describes this is a parallel healthcare policy trial with random allocation based on participants' identification method. And in the next point, we have to identify changes to methods after the trial commencement. Yes, the changes to Sweden cervical screening policy in 2017 during the study are noted, adapting to the national switch to the HPV-based screening. No, what is meant by the hazard ratio, parallel design, factorial design, and allocation ratio? Hazard ratio means a measure of how often a particular event happens in one group compared to another over time. For example, an hazard ratio of 0.283 in this study means HPV-based screening reduced the risk of cervical cancer by 17% compared to cytology-based screening. The parallel design that is also adopted in this study, a trial where two groups, for example, human papillomavirus-based versus cytology-based, are treated simultaneously and compared. And the factorial design means a trial design testing multiple interventions simultaneously, which is not used in this study. Next is the allocation ratio. It means the proportion of participants assigned to each group. For example, that may be 1:1 or 2:1. Here it is not explicitly balanced or not otherwise mentioned. Here it is mentioned that there are 2,12,190 women in HPV group and 1,83,120 women in the cytology group. So it is not explicitly mentioned in this article whether it is 1:1 or 2:1. Next, for the participants, we have to identify the eligibility criteria for the participants. Yes, women aged 30 to 64 years eligible for the cervical screening were included. Women with prior diagnosis or invasive cervical cancers were excluded. And next, we have to identify the setting and location where the data were collected. The trial was conducted in the organized cervical screening program of the capital region of Sweden, involving women resident in the Stockholm and Gotland. And this screening, the samples were collected by the trained midwives. Interventions. The intervention for each group with sufficient details to allow participation, including how and when they were administered. Yes, the intervention include HPV-based cervical screening with cytology triage of HPV-positive women compared to cytology-based screening with HPV triage for abdominal results. Detailed processes for triage, follow-up, and referral were described. Next, we have to move to the outcomes. We have to identify the completely defined pre-specified primary and secondary outcome measures, including how and when they were assessed. Yes, the primary outcome that they were stated that is the long-term protection against invasive cervical cancer, while the secondary outcome is detection of cervical intraepithelial neoplasia grade 2, that is also known as SIN2. Outcomes were assessed using national cancer registries. Next, we have to identify any changes to trial outcomes after the trial commenced with the reasons. Yes, the study adopted to Sweden's national switch to HPV-based screening in 2017, transitioning the cytology group to HPV screening. Now, the sample size. We have to identify how the sample size was determined. No, the trial was powered to assess non-inferiority in detecting SIN2 plus at baseline and included 3,95,319 eligible women. However, they have not stated how the sample size of this woman was calculated. Next, we have to identify when applicable explanation of any intern analysis and stopping guidelines. Intern analysis and stopping guidelines were not described In now, what is meant by the intern analysis? In randomized control trials, interns should check randomization balance, clean data, analyze primary and secondary outcomes using appropriate statistical tests. That is, that may be t-test or chi-square test. They must ensure adherence to intention to treat principles and document results clearly with reproducible scripts. Next, randomization. Whether the article has given the method used to generate the random allocation sequence, yes, the randomization was based on the last control digit of participants' personal identification number. And for randomization, they use a coin for the task and use the large digit of their pin code uh, that is given to them at the time of their birth and remain throughout their lives same. Next, we have to recognize type of randomization, details of any restrictions such as blocking and block size. Yes, randomization was unrestricted and based solely on the pin system. The randomization is unrestricted. Going towards the allocation concealment mechanism, whether they have used mechanism to implement random allocation sequence, whether sequentially numbered containers describing any steps taken to conceal the sequence until interventions were assigned. This was not applicable as concealment was not implemented as randomization was based on public pins and thus not concealed. They have given that the concealment they have not concealed any information. Next is the implementation. Who generated random allocation sequence, who enrolled participants, and who assigned participants to interventions. Yes, this point is explained in the article that randomization was generated automatically based on pins, the last digit of the pin, and participants were enrolled through routine invitations in the organized screening program. Next is the blinding. Whether the article has done blinding, and if done, who was blinded after assignment to the interventions, whether participants, care providers, and those with outcome. That is level 1, 2, or 3 blinding. No, blinding was not applicable as the policy trial required full transparency regarding the assigned screening type. Next is description of the similarity of interventions. Yes, both HPV-based and category-based screening use the same liquid-based cytology system for sample collection, ensuring methodological consistency that was collected by the trained midwives. Now, the statistical methods. The statistical method used to compare groups for primary and secondary outcome. Yes, Kaplan-Meier survival analysis and Cox regression were used to estimate hazard ratio and compare groups. Log rank tests were applied for differences between policies. Next is whether the methods for additional analysis such as subgroups and adjusted analysis. Yes, post-hoc analysis including stratification by age groups and histopathological subtypes of cervical cancers was given. No, I will try to move towards the article. Here is the methodological section. There it has explained that the data was collected between 2014 to September 2016, and data was collected by the in the capital region of the Sweden. They have enrolled 3,95,319 women, and randomization was done on the basis of last digit of the pin and by the toss of the coin. And there was no conceal of the randomization status. And here is the flowchart diagram where they have concluded that initially 3,95,000, more than 3,95,000 women were recruited between the ages of 30 to 16, and among them 406 women with diagnosis of invasive cervical cancer uh, were excluded. They were excluded based on their cervical cancers. The leftover was 3,95,319. Then they were then they were allocated in two groups. The HPV screening group and the other one is cytology based screening group that is given below here. So this is the flowchart diagram that is given here. They have given their outcome, the primary outcome, that is the relative rate of cervical intraepithelial neoplasia, grade 2, and They have also given the secondary outcome, that was the long-term protection against invasive cervical cancer carcinoma. They have also given here their statistical test, that is the Kaplan-Meier curve, Cox regression analysis, and others. Now going towards the slides. Next is the results participants flow. Number of participants randomly assigned received intent treatment and analyzed for primary outcome. Yes, a detailed flow chart is provided, as I have shown, that shows that there are initially 3,95,319 women enrolled, with 2,12,119 allocated for HPV-based screening and 1,83,120 for cytology-based screening. And then they have to address losses and exclusions after randomization with reasons. The reason for exclusion and including protocol violations, inadequate samples, and participant loss to follow-up was given, as I have shown in the flowchart diagram. Then is the recruitment. Dates of defining periods of recruitment and follow-up. Yes, as I have already shown in the article, that the recruitment was conducted from September 2014 to September 2016 with follow-up until December 2022. Why the trial was ended or stopped? Yes, they have explained that the trial was stopped in January 2017 due to next adoption of Sweden HPV-based screening program that is conducted nationwide. So the trial was stopped in January 2017. Next, the baseline data. Whether the article has stated about the baseline data, a table showing baseline demographic and clinical characteristics for each group. Yes, the table was given in the article, which shows the baseline characteristics including age and screening history, and data summarized in prior publications and referenced in the appendix also. Now the numbers analyzed. For each group, the number of participants including in each analysis and whether the analysis was by original assigned groups. Yes, the numbers analyzed for both intention to screen and per protocol populations are reported along with detailed breakdowns of events. Next is the outcomes and estimation. Results for each primary and secondary outcome and estimated effect size and precision. Yes, human papilloma virus-based screening reduce cervical risk, cancer risk by 17% in intention to screen analysis. That is hazard ratio is 0.83 with 95% confidence interval, and 28% in per protocol analysis. The hazard analysis is 0.72, confidence interval is 95. Now the binary outcomes and the absolute and relative effect size. Yes, the absolute risk reductions and relative hazard ratios are presented for key outcomes. Next is the ancillary analysis. The results of other analysis, including subgroup and registered analysis. Yes, subgroup analysis by age, histopathological types, baseline test results are reported. Exploratory analysis are highlighted risk differences in HPV 16-18 positive women with normal cytology. Next is the harms. All important harms are unintended effects. Yes, adverse effects including higher referral for colposcopy in HPV policy group. Now the coming towards the discussion, the article has given its discussion comparing its results with the already published results. We have to describe whether the trial limitations and addressing potential bias, imprecision, and multiplicity of the analysis. Yes, limitations including imbalance in randomization, non-concealment, and lack of extended HPV genotyping during the trial. Next is the generalizability of the trial findings. Yes, findings are applicable to organized screening programs, but may differ in countries without established human papillomavirus vaccination program. Next is interpretation consistent with results, balancing benefits and harms. Yes, the interpretation highlights the benefits of HPV-based screening, balance against increased colposcopy, referrals, and resource demand. Other information is related to the registration number and name of the trial registry. Yes, the clinical healthcare trial policy was registered at the clinicaltrials.gov, that is given its number, and where the full protocol can be accessed. Protocol details are in appendix and registered in the clinicaltrial.gov. No, the last point is whether the sources of funding and other sports groups are given or not. Yes, they have given their funding source, that is Swedish Cancer Society and European Union Horizon 2020. So overall, this article is a very good article. It has addressed all the points according to the consort checklist. It has given flow charts, tables, and other necessary information that has to be included in the consort checklist. So this is our YouTube channel where all the presentations from the community medicine department are uploaded here. And thank you very much for today's general club. If anyone has any question related to the general club, please ask.